In this video, we discuss the case of a 30-year-old female patient who presented to us 20 hours after the injury to her right eye with an iron wire. There is a full thickness corneal laceration with rupture of anterior lens capsule. The IOL power was calculated from the left eye and a gentle B scan of the right eye was unechoic. In the operating room, we form the anterior chamber with a dispersive OVD. The first step is to suture the corneal tear with the help of a single interrupted 10-0 nylon suture. After ensuring a watertight closure, we bury the suture knot. Another side port is created to facilitate the aspiration of the loose cortex from the anterior chamber as the anterior lens capsule is ruptured. Removal of traumatic cataract is imperative in this case to avoid post-operative inflammation and rise in intraocular pressure. Now we stain the anterior capsule with trypan blue dye to visualize the anterior lens capsule tear. The anterior lens capsule is trimmed using Warner scissors and Rexis forceps. Once we have adequate access to the cataract, we go ahead with the phaco probe. But realize that irrigation and aspiration cannula would be an ideal choice as the lens is very soft. We are careful to avoid any fluctuations in the anterior chamber as we are unsure of the status of the posterior capsule at this point. So before we withdraw our irrigation cannula, we inject dispersive OVD from the other side port. Since we have calculated the IOL power from the other eye, the plan here is to implant a 3-piece IOL if the posterior capsule is intact. Primary implantation in the same sitting has the advantage of faster visual rehabilitation, it is more cost effective, and it is easier to place the IOL in the back since anterior and posterior lens capsule is not fused. The anterior lens capsulotomy is extended to achieve a good overlap of the intraocular lens. In the end, we realized that the tear was leaking due to change in fluidics after cataract surgery, and therefore we put in another additional suture. And then we bury the knot in place. At first day post-op, we have a quiet eye, and at 2 months follow-up visit, her best corrected visual acuity is 6/12, and we have a happy patient as well as a happy surgeon.